Okay, let's jump right into this explainer on the public health impact of immunization. Today, we're going to explore everything from those massive historical victories that changed the world to the very real modern medical ethics that shape how we protect our communities today. Here is exactly what we'll be covering. Number 1, a public health triumph. 2, how vaccines actually protect us. 3, the UK immunization schedule. 4, navigating live vaccines. And finally, number 5, the challenge of hesitancy. Section 1, a public health triumphs. To really appreciate where we are, we have to look back at the stakes before vaccines. Take polio, for example. It routinely caused permanent paralysis, literally putting patients in these massive iron lung wards just so they could breathe. It's a heavy image, right? In the mid-20th century, annual cases in the US alone were often well over 10,000. But today, thanks to the polio vaccine, those global cases have plummeted by more than 99.9%. That is a massive public health win. And when you zoom out and look at the whole globe today, the numbers are just staggering. Immunization worldwide averts an estimated 3.5 to 5 million deaths every single year. So it's not just about stopping an infection, it's keeping people out of hospitals, keeping our healthcare costs manageable, and honestly, keeping the global workforce healthy and productive. But the absolute ultimate triumph has to be smallpox. We are talking about a disease with a devastating 30% mortality rate that took millions of lives over centuries. But through this incredibly intense, targeted global campaign by the World Health Organization, the disease was cornered. The last naturally occurring case was in Somalia in 1977, and by 1980, it was completely eradicated from the planet. Just gone. Section 2, how vaccines protect us. So let's get into the mechanics of this. The really crucial takeaway here is that vaccination isn't just a personal health choice, it's a community shield. When enough people are vaccinated, and for highly infectious stuff like measles, you need a really high threshold, like 95%. It makes it incredibly hard for the disease to find a host and spread. This is what we call herd immunity. And that communal shield, it is absolutely vital for the people who cannot get vaccinated. Think about newborns who are just too young for their shots, or elderly folks whose immune systems are naturally winding down. It also protects cancer patients going through chemotherapy, or anyone with a severely compromised immune system. For these groups, our collective immunity is literally their main and sometimes only line of defense. Now, to really grasp the science, we need to clear up two terms that get tossed around and confused all the time: efficacy and effectiveness. Efficacy is the controlled lab stuff. It tells us how much the vaccine lowers risk in a pristine clinical trial. Effectiveness, though, is what actually happens when you unleash that vaccine into the messy, unpredictable real world. Let's break down exactly what an 80% efficacy actually means, because it's super misunderstood. It doesn't mean the vaccine only works 80% of the time, or that a random 20% of people get zero protection. No, it means that if you take a vaccinated group and compare them to an unvaccinated group, 80% fewer people in the vaccinated group will contract the disease when exposed. It's a huge reduction in relative risk. But look, because biology is complicated and no vaccine is a 100% magical force field, breakthrough infections can happen. And that right there is exactly why we need high community buy-in. When the vast majority is vaccinated, the germ just doesn't circulate as much, which drastically lowers the chances of anyone, even vaccinated folks, coming into contact with it and having one of those breakthrough infections. Section 3, the UK immunization schedule. Okay, let's look at how all this science is applied in the real world, starting with the foundation. In the UK, the primary series for infants kicks off right at 8 weeks old. Babies get these amazing combination vaccines, like the 6-in-1, which builds a baseline immunity against major threats: diphtheria, tetanus, whooping cough, polio, Hib, and Hep B. They also get the MenB vaccine and oral rotavirus drops. And all these are carefully spaced out to safely build up full protection during those vulnerable early months. Then, as kids grow up, they get boosters and new protections. At 1 year, it's the MMR for measles, mumps, and rubella. School kids get an annual nasal spray for the flu, and around 12 to 13 years old, they get the HPV vaccine, which is incredible because it actively protects against cervical cancer and genital warts. And it doesn't stop there. The schedule goes right into adulthood, offering targeted vaccines for older adults like shingles, pneumococcal, and those yearly flu boosters. Section 4, navigating live vaccines. Now, within that schedule, there's a specific type of shot we need to highlight: live vaccines.
These use an attenuated or weakened version of the actual virus or bacteria. You'll definitely recognize some of these, from routine childhood ones like MMR, the rotavirus drops, and the nasal flu spray, to targeted ones like BCG for tuberculosis or varicella for chickenpox. It also includes travel essentials like yellow fever and oral typhoid. Now, for the vast majority of us, these live vaccines are perfectly safe and highly effective. But they have strict rules or contraindications for high-risk groups. Because they contain a live pathogen, even a weak one, immunocompromised patients or pregnant individuals absolutely have to avoid them. Healthcare workers also have specific rules to protect themselves and their vulnerable patients. And if you're immunosuppressed and need to travel somewhere that requires a yellow fever shot, you actually have to secure a specific medical waiver from a travel clinic. It's all about carefully managing that risk.
Section 5, the challenge of hesitancy. Finally, we have to talk about the human element, because vaccine hesitancy is a massive and complex challenge. People hesitate for all sorts of reasons: lack of trust, fear of side effects, misinformation, or even just bad access to a clinic. Our source material brings up a great quote: "Jaw is better than war." It's a reminder that getting past hesitancy doesn't come from arguing or coercing people. It comes from having real, patient dialogue and transparent communication. To actually have those productive conversations, healthcare providers use a framework called the empathetic refutational interview. It's 4 steps. First, you just listen and elicit their concerns. Second, you affirm their values. You acknowledge that, hey, they just want to keep their family safe. Third, you gently refute the misinformation based on what's motivating their fear. And then only in step 4 do you hit them with the clear, factual data. Empathy has to come first. Which brings us to a really fascinating ethical dilemma: the free rider problem. This happens when someone refuses to get vaccinated, but they still get to stay safe because the rest of the vaccinated majority provides that herd immunity. They're reaping the rewards without chipping in. It raises some pretty deep questions about social responsibility and fairness in a community. And that leaves us with one final, very provocative question to chew on. As individuals, we absolutely have a fundamental right to bodily autonomy and informed consent. But at the same time, society has a clear obligation to protect its citizens, especially the vulnerable ones who rely on us. So how exactly do we balance that individual freedom against the collective necessity of the public good? It is the ultimate tightrope walk in public health. Thank you so much for joining me on this explainer, and keep asking the big questions.